ultimately to try to provide you hopefully useful information and updates. Before we get started, maybe just have a quick word of prayer. Most gracious Heavenly Father, we thank you again for another day, for another opportunity to share with each other and one another, to hope that we can, in the sharing, remunerate the love and generosity that you've given to each one of us. We ask now that you help us be open to the information that's shared. Be with me as I try to convey what I've learned and what I've experienced over the last weeks that may be helpful to someone. In Jesus' name I pray, amen. Okay, I think I know most of the people who's on here, and I appreciate you for taking the time. I want to jump right in this. Last week, we spent some time setting the ground work about what is COVID or coronavirus or nCoV. nCoV is just a term that's used when we talk about novel coronavirus, so that's the virus. We talk about COVID-19, we're talking about the disease itself. So we kind of use them interchangeably. But last week we talked a little bit about what is it, where it came from, how it's transmitted, etc. And this week what I'd like to do is to just talk a little bit about the trends over the last week in California and Los Angeles County pretty quickly. I'll update us on a couple of the orders that were passed out by the Department of Public Health, which I think most of you all know about. And then there were several questions that were already submitted. I'll try to answer in a concise fashion. If we have time after that, any questions that you might have, please feel free to kind of queue them up, and hopefully we'll have time to kind of address those as well. So again, you know, coronavirus or COVID-19 is a virus much like influenza and a number of viruses, and I showed this slide last week. Is spread through two primary means, right? Droplet contamination, which then can either be inhaled, or droplet contamination on the surface, which then after being touched can be transmitted through the eyes, through the nose, or through the mouth, any mucous membrane, and then the virus sort of enter the system that way. And so again, it's just kind of easy to remember. It's no different than the flu in that regard, although to some degree a little bit more contagious than we typically think of with regard to it being transmitted by our hands. Now, when we think about someone getting the disease, it's really kind of important to remember that there is sort of a period of time unknowingly that we are exposed or susceptible, if you will, to the disease. And I say unknowingly because most of the time people are getting exposed because they've touched a surface with a droplet, or maybe even been exposed to a person who's asymptomatically shedding the virus. So this period of exposure is there sort of unbeknownst to us when we're out and about, either at work or in the community or even at a store, for example. You see on this slide this sort of difference between the onset of symptoms and it becoming contagious. So there's a gap of days between becoming contagious and actually showing symptoms. And this is what we call this asymptomatic shedding phase, which is very important because this is why this disease is so different than so many other diseases like the SARS epidemic before the MERS epidemic, where people for the most part were contagious and also extremely symptomatic at the same time. So this is why this is so different and why it spreads so quickly through the community. You can see that as low as 7 to 10 days, but as high as actually even 3 to 4 weeks, people can be infectious, even after they are clinically feeling better. So again, this sort of widespread opportunity for infection is what makes this such a really difficult disease. With regard to trends in California, I showed this slide last week, and you may not remember it, but the total number of cases last week, just a week ago, was 15,000 cases. So in 1 week, we've gone from 15,000 to 25,000 plus cases, right, in the state of California. And we've gone from about 380 deaths to 780 deaths in 1 week. I also showed you the curve to the right, And the curves to the right are just sort of curves that try to project whether or not we're sort of leveling off versus still staying straight and being sort of on this exponential growth. And all of the curves, at least this week, even though we're still seeing an increased number of confirmed cases, show for the most part in most counties, we're starting to level off. So again, leveling off doesn't mean that there is lower risk. Leveling off doesn't mean that there aren't more cases, because even though we're leveling off, we can see that we have 10,000 more confirmed cases in 1 week, and almost, or I should say more than twice the number of people who've died. And that's because there's always going to be a lag in the leveling off versus people being diagnosed or people having symptoms. If we look at the California trends by day, and this is actually just downloaded this afternoon, again, don't be fooled just because you see these curves, new cases per day, it looks like it's sort of leveling off. The number of deaths per day seems like it's trying to level off. Don't be fooled by that to think that your risk is lower, therefore you can go out in the community and do your normal thing. Again, these numbers oftentimes lag in terms of your risk for actually getting infected in disease. And we still will see newer cases over the coming weeks, as well as newer people getting sick and more people dying from this disease all over the country, but especially here in California and in Los Angeles. So even though we've so-called flattened the curve, we still have a very significant risk. This is directly from the Department of Public Health website, and it shows, again, in Los Angeles County alone, we have 10,000 cases cumulatively. That's 40% of all the cases in California in our county alone. Now that shouldn't be a big shocker for most people, but again, that means that the majority of the risk in California is right here in our backyards. And nearly half of the deaths in California are in Los Angeles County. So even if things are flattening out and you hear all this good thing on the news, all the good reports of the news, the risk in Los Angeles County in our backyards is still quite significant. 22% of the ages, 22% of the people who actually are getting this disease are over the age of 65, which means that over 75% of the people are younger than 65. Now that detail is in the chart. It may be hard for you to see, but this is extremely important because it means that 3 out of 4 patients who get coronavirus and become symptomatic are younger than 65 in LA County. We'll talk a little bit about why that is, but this is extremely important. So people on this call who are, well, I don't know how many 30-year-olds we have on this call, but I know we have some 40s and some 50s on this call. We're actually represent the majority of people, at least by age, who are getting this disease in LA County. So don't let the smooth taste fool you. Don't think that because you're not 67 or 68 or 70, that you're free from risk, because that is not true. In my inpatient or in my huddles every morning, when I'm talking to people across the system, the majority of people are adults who are inpatient. So we nearly have at any given day 300 or so people who are in our hospitals across LA County who are sick enough to be in the hospital. Now, almost half of those people who are in the hospital are in the ICU. And almost half of those people have a tube down their throat helping them breathe. So again, very important to recognize, if you get sick and you have to go to the hospital, half the time those people end up in the ICU, and half the time those people end up intubated or with a breathing tube. So this is a very, very important and severe disease if you get it, and that's why prevention is so important. Now on Friday, you may or may not have seen, there was actually a press conference that tried to paint the picture of a number of scenarios in LA County specifically, based on whether or not we continue to implement the stay-at-home order and the physical distancing. And what is on this slide, and for those of you who may not actually see the slide, is basically 4 different sort of scenarios or graphs, depending on whether or not we actually are really aggressive with the physical distancing or we sort of let up. And what you can see looking at a graph like this is that regardless of what we do, it is very likely that we're going to still see an increase in the number of people who get the disease. What physical distancing does is it just delays it. Why is delaying so important? Delaying this is so important because it actually decreases the number of people at any given time who will have an active infection and therefore become symptomatic. So in this next graphic, what they tried to do in the press conference on Friday was to basically demonstrate how many people in LA County would get the infection if we basically never did social distancing, or if we maintained current levels, or if we were more aggressive. And what this graphic shows that if we never did social distancing at all, virtually 100% of people by August 1st would have been infected with COVID-19. Now you might say, and I'll talk about this with herd immunity, that's not such a bad thing. We kind of get over it very quickly. And while that's true, a lot of people will die because we don't have the resources to care for them. So that's why so many people being infected so early is a bad idea. If we maintain this same level by August 1st, about 30% of the people will actually have been infected. Now, again, only 20% of people or so will be sick enough where they might have to come to a hospital, and only 3% to 5% of people will actually have to stay in the hospital. So you just start doing the math before you see how many people are in the hospital at any given time. If we are more aggressive and maintain our physical distancing, we can actually limit the number of people who will actually become sick or will have symptoms to less than 5%, or around 5%. And again, 1 in 20 out of 11 million, still a lot of people. So again, just remember that this is something that the longer we do this, the more we sort of spread this out over time. And what that does is allow our health system to be able to care for people, as well as buy us time to develop treatments and a vaccine. I'm going to come back to that. So this is the prediction or demand in LA County model that was used, and it was actually presented to LA County health officials and the health officer, as well as presented to the governor, Gavin Newsom. And basically this sort of slide or data says, even with a significant margin of error, our model predicts that if we maintain social distancing, we will not overwhelm our capacity to care for the number of people who will get sick. So this is our responsibility to ourselves and to each other. And it's the precursor to the answer of why it will take longer than maybe just another few weeks to sort of whip this bug. It's why it will take months and months, if you will, to really lick this thing. And it's again, so that we don't overwhelm our health system, which means we have to limit the number at any given time who are infected. I hope that makes sense. Okay, there were 2 health officer orders that are updated, given on Friday. The first was, and I think everyone has seen this, the Safer at Home order was extended to May 15th. I think everyone has seen that. I hope everyone knows that it means that all the limitations that were put in place before will extend at least until May 15th. The second was guidance provided about cloth face covering for being in the public. And the detail of the order simply says, if you're going to leave your home, put on a face covering. That's that simple. Not just when you go to the market. If you leave your home and you're walking the street, have a face covering on. That's the new order. And it's not just the city, which was the prior ordinance from the mayor. It's actually LA County. Now, people ask all the time, is this enforceable? Are you going to get arrested? No, you're likely not going to get stopped by the police or arrested, but you might be accosted by a neighbor or someone arguing with you to put on a mask in their presence, or they may be taking a very wide angle around you because now people are more cautious and concerned about people not wearing masks. And again, the idea is to protect you and to protect others. So again, these 2 orders in the last week came out. One is that the Safer at Home order will be extended to May 15th. And the second is everyone going out in the public should have at least a cloth face covering on. Okay? All right, so that kind of brings me to the first questions. All right? How long are we realistically looking at the Safer at Home order? Well, the best answer is for a while. And for a while means at least a month. But despite what you might hear on CNN with regard to Trump, etc., remember, even though there are some people who believe that the warmer months might curtail this disease, there are plenty of warmer climates where this disease is actually running rampant. So we know that, again, the idea is that if we can stay away from each other, we can decrease the risk of infecting one another. If we can decrease the risk of infecting one another, we can decrease the number of people who get sick, who then might actually have to go to the hospital and be in an ICU. The fewer people who are in ICU, the fewer people who need a ventilator, the less likely people are going to die because we don't have the resources. So this safe-at-home order is going to be in place for some time. We still have a very small number of people who are infected, and we don't have a vaccine, and we don't have effective treatment. The reason why I say, and it depends, because it depends on the gamble that lawmakers are willing to make with the economy versus human lives. So again, it's this sort of idea of what do you care more about? People or paper? You know what kind of paper I'm talking about, okay? If you care about people and every person's life matters, then you're gonna be staying at home, safer at home for a while. And I mean for months, in some order or another. We will not, I guarantee you, go back to business as usual until we have a vaccine or we have or a very effective therapy. The other thing that we'll need before we even begin to make a dent at this is we'll have to have readily available testing on every street corner. And so until we can readily test people, until we can readily trace the people who are positive and where they've had contact, which is its own infrastructure resource, until we actually have effective treatment, and may I even say a vaccine, some form of this life we now call staying at home, telecommuting, wearing masks, etc., will be with us. And so, again, the graphic on the right is the Institute for Health Metrics and Modeling projects. And they popularized this yesterday. They published this report that as of June 21, there will be no one else who will die from coronavirus. And so this was popularized in CNN and the airways yesterday. And so if you were to just look at something like this, you might say, well, we have a month and a half at tops. We'll be so flat that it won't matter. Paper over people will win, and we'll be able to go back to our usual lives. Unfortunately, the Institute of Health Metrics and Evaluations model takes into so many assumptions. And these assumptions include things that if you don't read the detail, you won't understand. Those details include a more strict, a more strict sort of social distancing policy than we have in place right now. It includes widely available testing and our ability to trace everyone who's positive. Again, the infrastructure that we don't have right now, as well as a number of other assumptions. And so what I would say is please be very careful about the sort of hype that you read about sort of this going away in the near future. Mine and other public health people's prediction is that this is going to be with us for some time in one way or another. One of the reasons for this is related to this question here. What is herd immunity and does it apply to COVID-19? Herd immunity absolutely applies to COVID-19. And herd immunity simply is the ability for a population to resist a contagious disease because the majority of people in that population are already immune to that disease. So on this graphic, what you see are the people in green who have immunity to the disease, either because of vaccine or they're previously infected. And if a new person gets infected, but there are very few people to infect, and the number of susceptible people are very limited, the disease dies off very quickly. Herd immunity usually takes about 80 to 85% of the people in the population having immunity. The way we typically do that without killing a lot of people, without having everyone get sick or exposed, is a vaccine. So without a vaccine, the only way we get herd immunity is by letting a lot of people get infected. Hope that makes sense. Let's see, I think there was a question. So one of the questions, if there is a vaccine developed, do we have a choice to get it or not? Especially with talk of a chip being inserted in the US. I think that's a really good question. I think there's a lot to be paranoid about with regard to sort of the types of rights and privileges that could be compromised or taken away with this pandemic. Right? An emergency and the hysteria and anxiety is the ripe situation for people to force things down a population's throat. I think we have to be cautious about that. But I wouldn't let that keep you up at night. Remember, we're God-fearing, we're faithful people. We're not going to sit around worrying about some things that we can't control. However, vaccine, if and when a vaccine is developed and is safe to take, and proven safe to take, yes, we should, in a general, from a population standpoint of view, get vaccinated. So no different than the flu vaccine. And if we don't do that, again, one of the reasons we don't have 200, 300,000 people die every year because of the flu is because of the flu vaccine and herd immunity, okay? And we have a test and we have treatment. So because we have all three of those things, we don't have hundreds of thousands of people dying every year from the regular flu. And so we don't know whether or not COVID-19 is going to become like the flu or whether it's going to go away after it's gone like SARS did, okay, or MERS. We won't know that until this is sort of over, okay? So I hope that makes sense about herd immunity, okay? It's what happens in a population when the majority of people have immunity, and that prevents the infection of the contagion from spreading. The only way we typically get that is from a vaccine or because everyone gets infected. The reason why simple herd immunity tactics don't work now is because we don't have a vaccine and because the mortality of this disease is so high that if we let everybody get it, our health system will be overran, okay? All right, let me see, I think I had another question about this. Is it true that people who have ibuprofen in their systems have lower chances of recovery? We don't have really any data yet that ibuprofen or other anti-inflammatories, if you will, decrease the body's immune system from fighting or recovering from this disease. We know that Tylenol, for example, is an anti-inflammatory, even though it's used as an antipyretic, it's also an anti-inflammatory. There's been no evidence or connection that people who take Tylenol or people who take ibuprofen, particularly even for fever, that they have a reduced risk. Now, you will see sometimes reports of an association, but remember, you have to be very cautious about what you believe. This is just like this idea about Plaquenil, right? So Plaquenil, hydrochloroquine, this drug which someone just suggested on a whim that it might work, became something that everyone wanted to use, even though we have more and more data now, 3 weeks later, by a number of countries, that in fact, Plaquenil doesn't work. In fact, some people who are on the Plaquenil or hydrochloroquine did worse. So it's very important to remember that a lot of the observations that people get oftentimes are just associations, random, uncontrolled associations that are very difficult to control, and therefore kind of derive a conclusion from. So it's very, very important to kind of separate fact from fiction, okay? Let me answer this question. What groups are at higher risk for COVID-19 infection and its complications, and can the risk for these individuals be reduced? Now, again, I told you that there's really no great treatment, and I apologize for the slide being a little small, but let me just read this risk. Groups for getting infection, anyone almost who gets exposed can get the infection. So the risk is having a complication from the infection. So I can get infected, Derek can get infected, my children can get infected. Getting infected, this is a very contagious disease. Lots of people without risk factors can get infected. Once you're infected, having complications from the disease is what this group represents. So the groups at risk for severe illness or complications include people who are older. But remember, I told you, 75% of the people in LA County are younger than 65, okay? People living in nursing homes and long-term care facilities are at a higher risk. But it turns out, again, that the people working in the nursing home or long-term care facilities have had more infections, more complications than the skilled nursing facility residents themselves, okay, when you look at the Washington data. Obviously, having chronic lung disease like asthma or COPD, heart disease or heart conditions are higher risk, because if you have these conditions, it's a higher chance that you won't be able to tolerate the stress on your system. If you're immunocompromised, that means that you don't have an immune system, an intact immune system to fight the disease. Severe obese individuals have problems with lung mechanics. So it turns out that if you're severely obese, your ability to take a deep breath and expand your lungs, your ability to cough and get rid of infection is severely reduced. And therefore, severe obese people have a higher risk of getting lobar pneumonia and other complications from this disease. So it's a very important thing. Like, people want to know, why is it that Americans, particularly our Black and brown folk, are getting this disease a little bit more? Well, some of it is because we have higher comorbidities, and some of that comorbidities has to do with an extra layer of tissue, okay, that we carry around. So the higher risk of obesity and some of the obesity-related diseases gives us these complications. And that includes diabetes, chronic kidney disease, as well as chronic liver disease, all of which occur more commonly in the African-American community. But it's these things that actually impair our ability to fight infection. So that sort of tees up the next question that was asked. Are African-Americans dying at a higher rate from COVID-19 infection? If so, why? The answer is, I left a reference to an article that I think is a very quick read. It's just 3 minutes long. It's published in Science and News just a few days ago. And it does a nice job of sort of explaining why African-Americans are a higher chance of getting COVID-19 or having complications from this. And the answer is yes, they represent a disproportionate number of people who are getting the disease and having complications from the disease and dying from the disease compared to their proportion in the United States. So if you said, what proportion of the United States population are African Americans? It's less than 15%. Some say maybe it's 12 or 13%. Yet, no matter what county, large urban city you talk about, be it New York, be it Chicago, even California, and everyone isn't reporting race data, by the way. Anywhere between 28 and 40% of people who actually represent hospitalizations, meaning they're sick enough, are African Americans. And that same proportion, if not higher, are actually dying. So we know, disproportionately speaking, African Americans are sicker, are getting sicker, are coming to the hospital often, and they're dying more commonly when they have disease. Now, why is this? Now, this wouldn't be, I think, a surprise for most of you guys. I talk a lot about social inequities and health inequities and disparities. And the graphic on the right just talks about all the sort of conditions, if you will, that exist that are, if you will, sort of predisposing conditions that exist in our communities, that exist politically, that exist socially, that we sometimes inherit, that are setting us up, if you will, for getting not only a problem, but having complications from that problem, right? So when you look specifically at COVID-19, think about the people who are more likely to get exposed or infected. Well, a lot of people are able to stay at home, but Black and brown people still have jobs that are supporting everyone who's staying at home. They're food workers, food handling workers, etc., and they're exposed and getting sick. They also represent a lot of the healthcare workers, particularly the lower end healthcare worker jobs as well, who are on the front lines, nurse assistants, people who are cleaning up in custodial jobs, etc. Phlebotomy, all those jobs, Black and brown folk. The housing is another big issue. We tend to be overrepresented in sort of congregate large housing. One of the biggest problems with New York City and New Jersey is that probably 65 to 80% of their population are in large housing complexes. Only a couple of ways in and a couple of ways out, everyone's touching the same elevator. Everyone is around each other. And that's just looking at getting in and out of the facility or the housing complex. Not to mention, for example, the fact that we have people living in close quarters in the same apartment. So this is really a housing situation that's in large part associated with our living conditions, which are, again, tied to the social political risk that we inherit as people. We also know that the root causes include chronic health conditions. We don't have to talk about that. Hypertension, diabetes, chronic liver disease, chronic kidney disease occur much more commonly in African American communities. Healthcare access with regard to both insurance status as well as disbelief and mistrust, for good reason, occurs more commonly in African Americans. Remember the Tuskegee experiment, right? So we have a short memory when it comes to people experimenting on us or people not treating us right. So this article that I showed you does a nice job describing these sort of four variables, if you will. And I think they're really, really important reasons as to why African Americans disproportionately are having complications and are dying from this disease compared to other folk. Can we do much about that? There are lots of people who are trying to provide resources, educate, test, go into the community, etc. But it's very, very difficult. And oftentimes we find that we don't have the infrastructure from a public health standpoint of view to deal with this, but at least has everybody's attention. Last question was, that was sort of a prefab question, was one about reusing personal protective equipment, such as masks and gloves. Can you reuse masks and gloves? So the cloth mask can be reused, of course. The recommendation is to try to wash it as often as possible. And you can wash it along with your laundry in hot water. That will kill the virus along with drying it in the dryer and the hot temperature. So the cloth masks, if they're durable enough, washing that in the washing machine, the hot water, hot cycle with hot drying heat is totally fine for masks. If you actually are talking about a paper mask, like a surgical mask or an N95 mask, something you got from Home Depot, how can you clean that? Well, you have to be very careful about these masks because they're friable. These masks can begin to fall apart and they can micro-puncture. One question I oftentimes receive is, can you use Lysol or some disinfectant to spray the mask down? And yes, you can, but just remember to let that completely air out and dry before you put it on and inhale that vapor. So Lysol is something that you can use, but again, spray it very lightly. If you spray it too damp, the moisture from the Lysol itself will then begin to break up some of the adhesive connections of the mask itself and may make it now a faulty mask. So just be careful and make sure that the mask itself always has the same integrity that it's had in the past as you continue to wear and clean that. Most masks are designed for single day use. They're not really designed to use day in and day out, 4, 5, 6 days, weeks on end. Even though they kind of look okay, they actually are not functioning okay. All right. What about gloves? Most gloves, unless you're talking about very thick gloves, again, are designed for single use, if you will, or single day use if you're at the job. Most of the typical nitrile gloves that are sort of the lavender gloves that people have bought are super thin. And there's a really nice study that was done in dental offices that looked at dental gloves that are actually even more durable than these gloves that most people have access to. And they've looked at dental hygienists and dental assistants washing their hands throughout the day using the same gloves and trying to see if there were micropunctures that you could not see with your eye, but whether or not it was still infecting the hands. And the answer was yes. They tried 4 different types of medical grade gloves. And if you took those medical grade gloves and you washed them throughout the day, and again, multiple times throughout the day, these were the dental hygienists and dental assistants, that there were micro punctures in those gloves, again, which may allow for contamination. So my recommendation is if you're going to use gloves, I think they're fine. to use gloves. If you want to use them throughout the day, I think that's fine to use them throughout the day. If you're going to wash your hands, maybe once or twice at the most, but if you're going to wash them over and over again, even if they look okay, you're likely to probably have some micro punctures in those gloves. Most of those gloves are really designed for limited use and not to be used over and over again. Okay. Let's see. I know I have a few chat questions. I'll stay on for a few moments. There are a few questions. Let's see, are people on beta blockers or blockers at higher risk for poor outcomes? That's a really hard question. Again, this is one of those sorts of questions where we don't have enough data to talk about that. People who typically are on beta blockers are on beta blockers, which is a medication for heart disease or for hypertension. So these medications are usually taken for a really good reason. And I would not stop taking those medications because you've heard of some report about certain patients. Now remember, those same patients who are on beta blockers by themselves have higher risk because of the disease that they're taking the beta blockers for. So if you're on the beta blocker because of heart failure or because of heart disease or because of high blood pressure and you have kidney disease, those same underlying diseases are at higher risk for complications. And so it's not necessarily the beta blocker, but it may be the underlying disease. So again, be careful about reading too much into some of this information. The next question that's typed in is, how is the mutation of the virus being handled in the medical field as far as vaccinations being created? I'm seeing news articles where people are being reinfected with a different strain. How is the vaccination going to combat that? That's a great question. This is an RNA virus, meaning that it does have a risk of mutating, but the RNA virus really is about how it replicates more so than mutating. We do know that there currently are 2 dominant strains in the population, and even though coronavirus, there are lots of different mutations, there are primarily 2 that have been identified, and you do not have to actually perfectly identify every strain for a vaccine. What you need to identify are dominant proteins on the specific strain, or I should say on the specific type of virus, which is shared across strains to identify your vaccine targets. So this is something that the vaccine smart people have worked out for a long time. This happens every year. We know that for flu vaccine, we do the same thing. We're not perfect in our flu vaccines, but we identify enough of the proteins and molecules on the vaccine targets that we hope that our vaccines work. And by and large, our vaccines each year work pretty good. Not perfect, but pretty good. So the mutations are something in the long term that can happen, but in general, our vaccine folk are pretty smart about trying to identify what we call dominant proteins and develop vaccines towards that. Another couple of questions, and then if there aren't more, we'll kind of close out this week and sort of get ready for closing prayer. So the next question, if people get a flu shot every year, should we continue next year? And is the flu shot going to be separate from the vaccine? Great question. So yeah, this is a unique and different virus than influenza. And so influenza as a disease, as a seasonal flu, will likely be with us for some time. And the vaccines developed for influenza are targeted unique and different completely from COVID-19. So if and when they develop a vaccine for COVID-19, and if it is felt that we need to take it seasonally, particularly if the immune response that we develop isn't long-standing. Now, what I mean by that is, say I got infected with coronavirus last week. Currently, we do not know if my immune for that virus will last me several months, 2 years, or several years, like most infections. We don't know enough about this virus and our immune system to this yet. Remember, the first people just got this last November, right, December. So it's going to take some time and some experience before we know whether or not this is a virus that our immunity is going to wane over some time, meaning a few months, and we'll need to be revaccinated each year, whether or not our immunity will last for a year, whether our immunity might last for 5 years. The longer our own immunity lasts, the less likely we will need a vaccine at all. Again, so we'll just have to wait for some experience with this before we know really how long our immune system is going to really work against this virus or even being reinfected. Okay, the last question. I don't have asthma. However, I have family history of asthma. Does that mean if I get infected, my asthma trait will put me at risk? So that's a really good question. Everyone who has asthma doesn't necessarily know they have asthma per se. But what I will say is that most kids who have asthma know they have asthma. So a kid with asthma usually know they have asthma. Adults, on the other hand, may not necessarily know that they have asthma because the most common symptom that they might have as an adult might just be a little cough. And that's it. However, what I would say is that if you've had a cold or if you've gone through the allergy season and you haven't had much in the way of symptoms, rhinorrhea, runny nose, sniffles, or cough, it's unlikely that you have a significant amount of asthma that would cause you problems if you got infected with coronavirus. So it's a very good question. But again, I would say if you've been asymptomatic through the spring and sort of cold type symptoms and you remain fairly healthy, that's unlikely that you're going to have sort of hidden asthma that's going to now all of a sudden put you at a higher risk for complication. But again, really important question. And it just reminds me to tell you all that there are a lot of chronic illnesses that people have where they feel relatively well. So there are people who have hypertension who don't know they have hypertension. There are people who have diabetes who may not know they have diabetes, right? It's a chronic illness. They're sort of used to that. And so this is why even in this sort of day and age where we are sort of sheltered in place, where you have less access to healthcare, everyone on this phone has still access to healthcare, everyone. And if you haven't been checked or you don't know, you should get checked to be sure that you don't have hypertension, that you don't have diabetes. If you're someone who have borderline hypertension or borderline diabetes, you should be getting checked because the last thing you want is for your diabetes or your hypertension to be out of control and you be unaware of that and it be untreated and then you get infected. Okay, so it's a nice reminder that we need to still take care of ourselves beyond simply staying at home, washing our hands, and really kind of covering up when we go outside. Okay, so that brings me to the last of what I have prepared, and I think the questions that folks brought up. If there are any real pressing questions, I'll pause for a moment. Otherwise, good. Otherwise, I'd like to thank you all for taking the time to spend about 45 minutes with me today. We'll be back next week with more opportunity to talk and answer questions. I'll provide some updates with you on what's going on over the last week and then answer whatever questions that come up. Again, thank you all so much for your time and for your participation and look forward to seeing you again next week. Be safe, and I'll close this out with a word of prayer. Bow your heads. Kind, gracious Heavenly Father, we thank you again for the opportunity to share with one another, for providing me with the understanding and the wisdom that you've given me through my openness and willingness to learn and be a vessel. I hope that what I've shared has helped someone to better inform and care for themselves as well as care for, and inform, and share with someone else. Keep us safe until we meet again, and keep us mostly grounded in love and in faith. Amen. Okay, guys, take care. Thanks so much. I'll see you next week.